Next, I'll move to the spine examination. Like all exams, starting first with inspection of the spine. So I'll be looking at the back here and see whether the scapulae look about the same here on the left and the right. This one on the left is a little more prominent. That can be normal. Whether the top of the trapezius is about the same on the right and the left. It's a little bit more prominent on the right side here. I'll follow the spine down, looking both at the skin and whether the alignment of the spine is normal as well. Then I'll begin with palpation. I'll palpate starting up at the spinous processes of the neck here, applying fairly firm pressure here, enough that I can see white under my fingernails, and pressing all along the spine here, all the way towards the bottom, making sure there's no tenderness, no prominence of certain spinous processes over others. And then as I move down to here in the sacrum, I'll check the sacroiliac joints. This is where the sacrum joins the ilium. These are the joints right here, a little divot or depression that you typically can find on thin patients. Somebody can develop sacroiliitis or have arthritis in those particular joints. The next part I'll move to is range of motion, starting first with neck range of motion. So Nick, if you can touch your chin to your chest here. All right, and now look back as far as you can. All right, and then the next is rotation. So look over your left shoulder and look over your right shoulder. And then lateral bending. Try to touch your left ear to your left shoulder. And same thing, right ear towards the right shoulder. All right, so that's neck. Then I'll move into thoracolumbar range of motion. Again, first with flexion, so you can bend forward and try and touch your toes. And when someone bends forward, sometimes you can see that there's a little bit of a curvature of the spine that you may not have been able to see while they're standing upright. Now you can stand up again. And then if you can lean backwards, and I'm going to stabilize Nick as he's leaning back to make sure he doesn't lose his balance and fall. Okay, you can stand up again. And then the next part is rotation. So turn towards the left, your upper body towards the left as far as you can, and then your upper body towards the right. Again, keeping the hips and lower body still, so that's why I'm stabilizing here. And then the next part is lateral bending. Try and drop your left arm to touch the ground over to the left side. Okay, and now try to do the same thing on the right side. Try to touch the ground on the right side. All right. And that ends this part of the spinal exam. So now I'll perform the special maneuvers for the spine. These tests both check for whether there's any disc disease, that would be cervical disc or lumbar disc, pressing on nerve roots to cause symptoms. The first one is called the Sperling maneuver. So Nick, can you look up towards the ceiling and then turn your head to the left there? And now, so what Nick is doing currently is the space for the nerve roots to come out of the spinal cord is slightly compromised by this. And then I'm going to press on his head a little bit, and this will then further close down space if there is any disc disease. So I'm pressing on his head, and then I would ask, Nick, do you feel any symptoms in your arm at all here? No. All right. So what I've done there is press against the nerve roots coming out of the spine and traveling down the arm would give Nick symptoms of numbness or tingling if there is a nerve root compromise. So if he had problems on the left side, that would be the direction I would check. Can you turn your head the other way and look back up towards the ceiling again? There you go, just like that. And then I'll press here if he's having problems on the right arm to see whether there's any nerve roots that are compromised on the right side. So the next special maneuver is the test of the lumbar spine. If you can lie down, please, Nick. It's the same idea as the Sperling maneuver in that I would like to see if I can make the space smaller between nerve roots and spinal cord if there is some disc disease. So what I'll do is I'll lift Nick's leg here, lift it up to about 60 or 70 degrees or so, and ask Nick, are you having any discomfort down the front of your leg into your foot? This obviously will cause some stretch of the tendons of the back of the leg. The hamstrings will stretch. That's not the symptom I'm looking for. I'm looking for numbness, tingling, or pain in the leg in any nerve root distribution. That would be if he's having problems on the right side. If he's having any symptoms on the left side, then I will check on the left side, again lifting the leg up here at about 60 or 70 degrees or so. Any numbness, tingling, or pain on the left leg. All right. And so that's checking again on the left side. So if your patient had some discomfort with this test, I'm lifting this leg and the patient notes some pain or discomfort. Sometimes it's difficult to distinguish if that's hamstring or actually nerve root. So if the patient has pain at this level, you can lower the leg a little bit and then pull up on the foot. This will not involve the hamstring, but will then pull on the, or compromise the nerve roots and can cause similar symptoms. And the same thing would be true on the other side if there were problems there. And that concludes the special maneuvers of the spine. The next part of the exam is the hip exam, and starting first with inspection, of course. Now, Nick, could you lift your shorts on the left side here? So what I'm looking for in the hip is any swelling, any erythema along the outside of the hip area here. And could you lift the right side as well? And I'll do same thing, kind of looking at the right side. Then I'm going to palpate for the greater trochanter. Greater trochanters are located just about here, fairly prominent bones here that you can feel both on the left and the right side. There's a bursa located right in that area too, so if a patient had pain, it could indicate bursitis. If you're not sure where the bursae or where the greater trochanter is located, you can start just a little further south from there, working more proximally as you're pressing. You'll be pressing on the iliotibial band here, and then you'll approximate the greater trochanters right towards the hip here. After inspection and palpation of the greater trochanter, then you want to observe the patient's gait. And what you're watching for as he's walking is that there's some hip motion on both sides, both left and right side, and that hip motion is about equal. Then you move your eyes down to knees, and you watch and make sure knees bend and straighten about equally on both sides. And then lastly, you let your eyes go down to feet. What you see first is the heel is striking first, followed by the rest of the foot afterwards. And so what you see is pretty much a normal gait here, normal motion of hips, of knees, and of feet. So now the next part is range of motion and strength testing. This is best done with the patient lying on the exam table. So Nick, could you please lie here? And I'll pull this out for you. So I'll start first with range of motion of the hip, and I'll start with flexion. Can you bring your leg up, your knee as close to your chest as you can? All right, so this really is maximum hip flexion, but I can try and push the leg up just a little bit more to see if there's a little more flexion. All right, you can straighten that leg out and then do the same thing on the other side here. All right, good flexion on that side as well. Now, hip extension is best done with the patient lying on his side, so we'll check that in just a moment, and we'll jump ahead to abduction. Move your right leg out here as far as you can, and then bring it all the way across, and that's adduction that way. All right, now left abduction all the way out with your left leg, and then back across and adduction. Then I'll check hip flexion strength while the patient's lying down on his back, and then we'll move to the side. So if you can lift this leg up off the table, keep the knee straight, and I'm going to press against it. Check hip strength on the left side, flexor now on the left side. Hip flexion here, I'll press down. Okay, now you can turn onto your left side here, and I'll check first hip extension. So if you can move your leg all the way out back, okay, that's range of motion of hip extension, okay, and back. Now I'll check strength of hip extension, so press against my hand here and try to move your leg out. All right, now hip abduction strength, lift your leg up like this. I'm going to press down, keep it there if you can, and I'll press down against my hand. All right, so abduction and adduction. Now if you can turn over to the other side and face the wall, and I'll start first. If you can bring your legs straight and back out as far as you can. All right, good. And now I'll check extension of the hip here. Let me come on this side. So try and do that same motion while I'm holding your leg there. Now lift it up here, hip abduction, keep it there. I'll press down. And now hip adduction, press down against my hand here if you can. All right, so that's a range of motion and strength testing of the hip. And you can sit back up again here. Now I'll perform the knee exam, and the first part is inspection of the knee. I'm looking here at the dimples along the edge of the patella to make sure there are dimples. You can probably best see that here on this side. If those dimples are lost, that could be a sign there is an effusion in the knee or fluid in the knee. I'll compare one patella to the other to make sure they look about equivalent, and also just the general size of left and right knees. Then I'll go into palpation, starting first with the anterior knee. Here's the tibial tuberosity. This is where the patellar tendon attaches. So I'll press on the patellar tendon here and then up over the top of the patella itself. And then I'll check on the right side also. Tibial tuberosity, patellar tendon, and patella on the right. Then I can move more to the lateral joint or the lateral knee, starting first with the lateral collateral ligament, which runs along this aspect of the knee and attaches right to the head of the fibula, which you can easily see here. There's also the joint line that sits right above that. You can bend the knee a little bit to better assess the joint line here, which you will feel as a sharp ridge along the edge of the joint. I'll compare that on the right side as well, checking again the lateral collateral ligament, fibular head, and also the joint line. Then you move over to the medial joint line here, or the medial knee, where you feel the medial collateral ligament. You can't really feel it, but if a patient has tenderness there, they'll be able to tell you that. Lifting up the knee slightly, palpating on the medial joint line there. Then I'll move to the left knee, doing the same thing, checking the medial collateral ligament and the medial joint line. The popliteal fossa is what you want to palpate next, lifting up on the leg, allowing your fingers to go into or press into the popliteal fossa. You all know this technique from finding the popliteal pulse, but you can also make sure there's no swelling located there. And then also comparing to the other side. If there's a joint effusion, sometimes you'll feel that in the popliteal fossa. Now the next part is to check for range of motion of the knee. So Nick, if you can bring this left leg up and try to touch your foot to your butt. All right, that's good flexion of the knee, and bring it all the way back out again. And I'll see that there is at least full extension and sometimes hyperextension of the knee. If you can do the same thing for this right side, bring it all the way up and touch your butt. And if the patient is not able to do that, you can sometimes apply a little bit of resistance to see where the full flexion is, and then bring the leg all the way back out again. And then I'm checking again for full extension or hyperextension. In order to best assess strength of the knee, you ask your patient to sit upright. Nick, could you sit for me, please? So the first thing to check is knee extension. So Nick, can you press out against my hand? And then I can compare on this side, press against my hand here. Now pull back in towards you for, this is the flexion test, and pull back in towards you on this side as I'm resisting, and again, that's the flexion test on the right side, comparing right to left. Now I'll move on to the special maneuvers of the knee. And the first special maneuver is to check the medial collateral ligament for its integrity. What I'll do is I'll bring the right leg a little bit over to the edge of the bed. I'll flex it just a little bit. You see my left hand I'm holding and bracing against the lateral aspect of the knee joint, bracing against myself, and then using my right hand to pull the tibia towards me. So I'm holding the knee joint here, pulling the tibia towards me, and that is going to stretch on the medial collateral ligament in this location. Now I will check the lateral collateral ligament on the other knee so you can see that. Again, bringing the leg over the edge of the bed, dropping it in a little bit of flexion, resting my hand on the medial knee joint, and pulling the tibia towards me, again to assess the lateral collateral ligament. And if there is any laxity, there'll be more motion than what you're seeing there with the tibia pulling in towards me. I would, of course, check that on both sides here so that you could compare. The last test I'll check, the special test, is called the Lachman's test. This checks the anterior cruciate ligament, which runs across the knee like this. I'm going to hold the femur with one hand, and I'm going to bring the tibia up against it, up towards me. That's checking the anterocollateral ligament. If you do not have enough strength to be able to do that, you can bring your leg like this, holding his leg in position, and then bringing up on the tibia like this. And if there's laxity of the anterocollateral ligament, the tibia will come up further than what you notice there. And those are the special maneuvers. The next part of the exam is the ankle and foot exam, and I'll start first with inspection. And again, I'll compare one foot to the other foot, And so I'll look mostly at whether the top of the foot looks fairly similar, the ankle joint itself, looking for any deformities of toes, foot, or ankle. Then I'll move into palpation. And I'll begin with palpation of ligaments here. Along beneath the lateral malleolus, there are several different ligaments that sit just beneath the lateral malleolus here, and I'll palpate along those. Those can be sprained if someone has an inversion injury, turning his foot in with a fall. That's a lateral ankle sprain. Then I'll check on the medial aspect, again for checking the medial ligaments just below the medial malleolus. I'll compare that here on the left side as well. Ligaments for the medial, beneath the medial malleolus, and then the lateral ligaments. Then I'll next check the anterior ankle joint. You can best palpate that just beneath the tibia here. There are some tendons that run across that area, and that's where you'll palpate the joint. Then I'll move into the lateral and medial malleolus themselves to make sure there is no tenderness over the malleoli. Again, I'll compare on the right foot here, checking the anterior ankle joint and the lateral and medial malleolus. The next place to check is if somebody has a sprain, checking to see whether there's any tenderness over the proximal end of the fifth metatarsal here. And that is because that can be commonly fractured with an ankle sprain. And if I palpate pain in that area, when I believe someone has sprained their foot, I would instead get an x-ray to ensure this person has not broken this bone here at the proximal end of the fifth metatarsal. Again, I'll compare with the other side too, to ensure there's no tenderness in that area. Then the next place to palpate is the navicular bone. The navicular bone is just anterior to the ankle joint. Again, something that can be fractured if somebody has sprained their ankle and therefore has a foot fracture instead of an ankle sprain. You can see that best here on the right foot in this area, palpating over the navicular bone. I'll move to the posterior foot here for the Achilles tendon. The Achilles tendon attaches to the calcaneus, so palpating the most inferior aspect of the Achilles and then up through the tendon itself. There are several bursae that are located around the tendon that if there were pain in those areas, that could indicate a bursitis. So I'll again check on this foot, palpating here along the base of the Achilles, up through this area, and then where you can easily palpate it on the back of the leg here. Then there's another area to palpate on the plantar surface of the foot here. This is where the plantar fascia attaches. There's a large fascia that runs across the bottom of the foot and attaches here to the calcaneus. And someone can experience plantar fasciitis, and that would be tenderness right in this area. Plantar fascia is a little bit medial in its attachment to the calcaneus. And I'll check that also and compare it on the other side, palpating along the fascia and then at its attachment point in the calcaneus. While you can palpate all the toe joints, the most important one to palpate is the first metatarsal phalangeal joint. And just like on palpating on the upper extremities of the fingers, you can flex the joint a little bit, stabilize it with your hand, and then run fingers or thumbs along the edge of the ankle joint here to find if there is any pain or discomfort. Again, I can compare that with the first metatarsal phalangeal joint on the left foot as well, or on the right foot, excuse me. All right, so that is mostly palpation of all the bony prominences of the foot. Now I'll move into range of motion. So the first motion is plantar flexion. If you can bring your feet down, all right, and now lift your feet all the way back up. So that's plantar and dorsiflexion. Now inversion, if you can rotate your feet in so that the soles of the feet are pointed towards each other, good. And now rotate the soles of the feet completely out. That is eversion. Now I'll check strength. Again, I'm going to stabilize the joint here because I want Nick to use just his foot muscles when checking this, so I don't want him to use his knee muscles here, but if you can press up against my hand here, all right, and now press down against my foot here, or against my hand. So that checks dorsiflexion and plantar flexion on the left foot. Now I'll move to the right foot, press up against my hand, and then press down against my hand. All right, so that's plantar and dorsiflexion on that side. Now I want to check inversion and eversion in terms of strength. So if you can turn your foot in and point it towards the other foot, all right, now try to turn it out while I'm keeping it still there. All right, now turn your foot out all the way. Keep it out while I'm pushing against it, or you try and turn your foot in while I'm pushing. Okay. So mostly checking that on the left foot. Now I'll go to the right foot. Turn your foot in, pointed towards the other foot. Now don't let me turn it out. Now turn your foot out, and don't let me turn it back in again. All right, so you can see a little bit of checking inversion and eversion on either side. Now if somebody has a history of ankle sprains in the past or a current ankle sprain, you can check to see whether there's any laxity. This is a special maneuver of the ankle joint to check for ligament laxity. And what you want to do is, when you think about all these ligaments around the ankle, they should be able to hold the ankle fairly still in spite of your maneuverings. So if I pull ahead, you can let your foot relax. If I pull ahead on the foot like this, I'm pulling that foot against that ankle joint, and if there's any laxity of the ligaments, the foot will come forward quite a bit more than what you're seeing here. There's a little bit of motion forward and back as I'm stabilizing the tibia, but otherwise not much movement. And then I can compare it with the other side, of course, because if that side were fairly loose and this side were fairly tight, that would tell me there could be a problem there. And again, moving back and forth, you can see that there's a little bit of motion around the ankle joint as I am moving forward and backward. And that concludes the ankle exam.